Hello everyone, welcome back to my channel, that is Obstetrics and Gynaecology Simplified. Today we will discuss a very important topic. Okay, we are starting Gynaeoncology, that is the study of the cancers of the female reproductive tract. Okay, so this is a very important topic. You need to know all the cancers related to the female reproductive tract. There are various previous year MCQs where various MCQs are asked, many questions are asked on oncology, and also you get short note as well as long question of oncology. Okay, so let's start with premalignant lesions of vulva. So coming to the premalignant lesions of the vulva. So I've told you about the anatomy of the vulva. Now we will discuss about what are the premalignant lesions, how to identify, how to diagnose that, and what is the treatment. We will discuss in details. Coming to the premalignant lesions. So what are the premalignant lesions of the vulva? First, it is VIN, that is vulval intraepithelial neoplasia. Then second is the lichen sclerosus. Then Paget's disease of vulva. And squamous hyperplasia and Bowen's disease. These are the premalignant lesions of vulva. So what is the malignant part? The malignant part is the cancer vulva. So the premalignant lesions, these have a tendency to become malignant. So coming to the VIN, see, whenever we see any abnormal lesion in the vulva on inspection, if we find any suspicious lesion in the vulva, we must do or we should do the biopsy of the given area. Any suspicious lesion, biopsy is must. Because we do not know if that may be malignant, so we have to rule out the malignancy of that part of the vulva. So biopsy is must if we find any suspicious lesion in the vulva. Then coming to the nomenclature, see what is the nomenclature? Previously, the International Society for the Study of Vulvovaginal Diseases, that is the ISSVD, they did a nomenclature in 2004 that VIN usual type, that is vulval intraepithelial neoplasia of usual type, that is HPV related, and differentiated VIN. Okay. Then later the nomenclature was given by Lasts in 2013, that LCIL and HCIL. Okay, that means high grade and low grade. Then in 2020, this is the latest classification or the latest nomenclature that is given by WHO. That is in 2020 given, what it gave? It is HPV associated VIN and HPV not associated VIN. Okay, so this is the latest classification or latest nomenclature that is given, that is HPV associated VIN and HPV not associated VIN. HPV, it is the see, human papilloma virus. Okay, this is the most common organism or the most important organism that is associated with the vulval carcinoma and also the premalignant lesions. So what does HPV associated VIN include? That includes both LCIL and HCIL. Both high grade and low grade intraepithelial neoplasms are included in HPV associated VIN. And in HPV not associated VIN, what is included? That is DVIN, that is differentiated VIN, devil, and VAAD. What is the full form? See, devil is differentiated exophytic vulvar epithelial lesion. Epithelial lesion. And what about VAAD? That is vulvar acanthosis with altered differentiation. And these are not associated with HPV. Okay. Then what are the risk factors? See, first we just have studied about HPV. So HPV is the most common and most important risk factor. Also, the premalignant lesions are associated with smoking and multiple sexual partners. Also, in immunosuppressed women. Okay, in immunosuppression, HPV and smoking and with multiple sexual partners. So what is the types of VIN? See, this one is HCIL, that is vulval HCIL. Okay, so here what happens? 10% have pigmented lesion. Okay, in the vulva, only 10% have pigmented lesions. And this is, I've told you that both HCL and LCL are associated with HPV in the latest nomenclature in 2020 WHO. It has told that both LCL and HCL are associated with HPV. So it is associated with HPV infection. And we know that HPV affects multiple areas. Okay, this is a virus and it can affect multiple areas. So the lesions are multifocal. Okay, and it is how much? 50% of the cases are multifocal. Then what is the recurrence rate? 13 to 36% have recurrence after treatment. Okay, then about immunohistochemistry, see, P16 block like staining is positive. Means, what is block like staining? Means both nucleus as well as the cytoplasm is stained heavily. Okay, so that means both nucleus as well as the cytoplasm, nucleus plus cytoplasm, are stained heavily. Both are stained, means block like. Okay, so P16 block like staining is positive in VHCl. Then in histopathology, we see that it involves 1/3 of the epithelial thickness. 1/3 of the epithelial thickness. Okay. Then coming to the differentiated VIN. Okay. In differentiated VIN, this is, see, it take times and it is more differentiated, and here what happens, this is not associated with the infection. So what is the precursor lesion of the DVIN? The precursor lesion is that may be dermatosis or any skin lesions, okay, due to chronic skin lesions or due to chronic dermatosis or any abnormal skin lesions due to its presence, and when we do not treat that, that may lead to differentiated VIN. So what is the most common association with DVIN? That is lichen sclerosis. I will show you the image of lichen sclerosis and what happens in lichen sclerosis. It is a skin condition, okay, and the lichen sclerosis later, when not treated, that leads to differentiated VIN, that is vulval intraepithelial neoplasia, and that later on becomes malignant. Okay, so lichen sclerosis most common and also may be associated with squamous cell hyperplasia, and it has higher risk of progression to the malignancy or higher risk of progression, and it is P53 positive. Okay, in 83% of cases it is P53 positive, that is most of the cases it is P53 positive, and also Chi67 positive in the basal layer as well as the basal layer plus parabasal layer. This is the basal layer, okay, so this is the basal layer. This stains Chi67 as well as the adjacent layers or the parabasal layers also stain. Okay, this is the basal layer and the parabasal layer also stain in the by Chi67 in DVIN. And see, higher risk of progression. So what is the percentage? 32.8%. Okay. Then coming to the VAD, that is vulvar acanthosis associated with altered differentiation. What happens here? Three features. It is associated with three features. What are the three features? First, see, marked acanthosis, as the name suggests. See, it is vulvar acanthosis, so it is associated with acanthosis. Okay, so marked acanthosis with variable verruciform architecture. Second is the loss of granulosa, loss of granular layer with superficial epithelial cells. Superficial epithelial cells pallor. Okay, and third is multi-layered parakeratosis, that is more important. So that is associated or that leads to verruciform type of vulvar carcinoma. Multi-layered parakeratosis. Okay, then so this is the precursor lesion of verruciform carcinoma of vulva. Okay, then coming to the investigation. So what we do, how we investigate or how we see the lesions, we do vulvoscopy. What is vulvoscopy? That is examination of the vulva. How we do? We see by the naked eye, we carefully examine the vulva. Okay, so vulvoscopy, that is the careful naked eye examination, and if required we also with low power magnified examination may be needed. With low power magnified examination. Okay, that is the vulvoscopy. Okay, then what are the steps? First step is examination, visual examination. Okay, we see if any white plaques or any red patches or any erythematous lesion or any ulcer. Okay, these are the abnormal findings. Then we do visual examination. Then we apply application of acetic acid. We can apply acetic acid like we do in colposcopy, visual inspection. Okay, application of acetic acid. Okay, here in colposcopy, that is the examination of the cervix. What we do, we just keep it for the acetic acid, we keep it for only 45 seconds, but here we keep for 5 minutes. Okay, so more time we keep it or we apply, and then the concentration is 3 to 5%. Okay, we apply and we see if any acetoid lesion is present. If it is present, so that is abnormal. That means there may be any premalignant lesions of the vulva. Okay, then coming to the other test we can do, that is the Collins test. In Collins test we apply tolvadine blue. Okay, this is also a dye, that is a blue colored dye. Here what we see, if the areas are abnormal, that will be stained blue. So the abnormal areas will be stained blue. Okay, then we can do direct biopsy of the abnormal area, and I will tell you the indications of biopsy. Before that, see, this is the I'll tell you the indications of biopsy. Before that, you see, this is the 3-ring vulvoscopy. Okay, so in 3-ring vulvoscopy, you have the inner ring, okay, then the middle ring, and then the outer ring. Okay, so here is the inner ring. What is the inner ring? See, this one is the inner ring that consists of clitoris, okay, then subclitoral rhombus, urethral meatus, and this is the vestibule, that is the pinkish area that we observe, and see, this is the heart's line, and this is the hymenal rest. So these are included in the inner ring. Why we do the 3-ring vulvoscopy? So that we do not miss any area during the vulvoscopy examination. Okay, so this is, first we see the inner ring. So these are the areas that is included in the inner ring. Then coming to the middle ring. In the middle ring, what we see? See, this one is the anterior commissure and prepucium, and this is the interlabial sulcus, this is the labia minora, and this is the posterior commissure. So these areas are included in the middle ring. Then the labia majora, mons pubis, and the perineum. Okay, these are included in the outer ring. So we do not, this is the 3-ring vulvoscopy or TRIV, so that we do not miss any area during the vulvoscopy examination. Okay, then what are the indications of biopsy? Another examination, that is a biopsy. So if the lesion is fast growing, okay, or if it is, if any lesion that is present for more than 1 month, see what are the indications. First, if the lesion is fast growing, or any ulcer that is present for more than 1 year, for more than 1 month, sorry, ulcer more than 1 month duration, or any fields of bleeding, areas of induration, or if any lesion is present that is resistant to the medical management. Lesions that are resistant to medical management, we do biopsy. Okay, so that is the indications of biopsy. If the lesion is fast growing, okay, if the erythematous lesion, if we treat by medical methods and it does not resolve, okay, and if any ulcer is present for more than 1 month duration, and if any fields of bleeding or areas of induration is present, so we need to do the biopsy, and always incisional biopsy is performed and not excisional biopsy. Okay, means incisional biopsy means, let this is the abnormal area, okay, let this is the abnormal area, so we take a chunk of tissue, okay, this is the incisional biopsy from the normal and abnormal area. This is the normal zone, this is the abnormal zone. So we take a chunk from both, including both abnormal and normal, and that is sent for study. That is the incisional biopsy. So that we can know the invasion and proper or definitive treatment can be done. Then coming to the, this is the threading vulvoscoping, then coming to the treatment. See, what is the principle of the treatment in premalignant lesion? First, we try to manage the symptoms. That is the symptomatic management. Then complete excision of the tissue of the abnormal area, and also quality of life, and anatomy is we try to restore the anatomy. Okay, then what are the methods? First, surgical method, then medical methods, and ablative methods. In surgical method, we do wide local excision, or superficial vulvectomy. Okay, that is, we take 5 mm margins, and also we try to avoid taking the vital organs like clitoris, anus, urethra. Okay, we try to secure and not injure them and try to manipulate the margin so that these all structures can be saved. Okay, anatomy can be restored. And epidermis and minimal dermis are excised. Minimal dermis. Okay, and what is the medical method? We give imiquinone, that is 5% cream, and cidofovir. What are the ablative measures? In ablative measures, we can do CO2 laser or argon beam coagulation. Okay, so these are the ablative methods. Then coming to the Paget's disease of vulva. This is like we have studied the Paget's disease of breast. This is the Paget's disease of vulva. Okay, this can be, say this is an epithelial lesion, so it can be non-invasive as well as invasive. So let's write it arises from intraepidermal pluripotent stem cells. Okay, it arises from the stem cells, that is intraepidermal pluripotent stem cells, and that is mostly confined to the epithelium. Confined to the epithelium. And it has two forms, that is intraepithelial and invasive. Okay, so and this is found most commonly in post menopausal women. Okay, how does it appear? It appears as red lesions, patches, plaques with islands of white epithelium. Okay, so what is the appearance? It appears as red lesions. See, I will show you a picture. See, this is the Paget's disease. See, this is the red lesions. Okay, erythematous red lesion. Maybe patches or plaques with islands of white epithelium. Why white? Because of atrophy. The surrounding epithelium is atrophied and appears white due to loss of the subcutaneous fats, and the lesion itself appears as red. Then what are the symptoms? Symptoms is itching. Most vulval lesions that are present, the symptoms are itching, irritation, and bleeding due to injury or ulcer. Okay, that it can be primary or secondary. Primary means if the lesion arised primarily, if the lesion is from the vulval skin, that is the primary lesion, and if there occurs metastasis due to adenocarcinoma of the urological or breast or cervix or any colorectal carcinoma, then that is called as the secondary. So it primary means from the vulval skin, if it arises from the vulval skin, and second remains if it arises from any other place and it is deposited in the vulva. So it may be colorectal, breast carcinoma, CA cervix, and urological. Okay, that is from the bladder or urethra. Then what is the treatment? See, we do surgery. Treatment is surgery or excision of the abnormal areas, and if there is no invasion, if no invasion is present, what we do? We do same wide resection with 2 centimeter margin, with 2 cm margin. If invasion is present, then we do radical vulvectomy with lymphadenectomy. That means we do radical vulvectomy. That means a wide portion of the vulva that is removed, and also we do the pelvic lymph node dissection. Okay, inguinal and femoral lymph node dissection, and we can also apply imiquinone. That is, it has 90% of response rate, and also we can do phototherapy. Okay, phototherapy also can be given, as well as radiotherapy. So what is the differential diagnosis? Differential diagnosis is this is a condition that is called as lichen sclerosis. What happens here? Here there is subepithelial fat is decreased. See, here the fats are decreased and subepithelial fat is decreased, and labia is thin, atrophic, and fusion of the labia. See, this one is the labia is thin, okay, thinned, and there is fusion of the labia. We cannot just give a margin to the labia majora and labia minora. See, these are fused, okay, and thin, and also atrophied. See, clitoris also atrophied here. So this is the differential diagnosis of the Paget's disease of the vulva. What are the other differential diagnoses? It can be candidiasis or dermatophytosis. First lichen sclerosis. Differential diagnosis is first it is lichen sclerosis because it mimics Paget's disease of the vulva, and also candidiasis. And dermatophytosis, contact dermatitis, and psoriasis. Okay, and also it can be seborrheic dermatitis. So this is all about premalignant lesions of the vulva. In the next video, we will learn about the carcinoma of vulva. Okay, keep learning. Thank you.